Welcome to the Deep Dives. Today we are really cracking the code on a very systematic part of any physical exam. That's the assessment of the head, eyes, ears, nose, and throat, or, well, HEENT, as you'll often hear it called.
That's right. And our goal isn't just to, list the steps. We want to give you the insights to help you understand how health professionals use what seems like a standard checklist, but they're actually converting these sometimes tiny observations into really powerful diagnostic clues about everything from, say, thyroid function to neurological health.
It's a fascinating area, isn't it? Because it's where all our key senses, our major entry points to the body, meet the control tower, the brain. We've gathered a whole stack of sources detailing this. And our mission today, pretty simple, really, demystify the four main techniques they use, highlight some of the maybe surprising tools needed, and critically, define that line between an expected finding, normal health, and a genuine red flag.
Exactly, because if you understand what the practitioner is looking for, suddenly those gentle pokes and prods in the clinic, they make sense. They become part of a compelling system check.
Okay, let's dive in then. Let's start with the groundwork. When a professional walks into the room, what are the fundamental techniques they're relying on for all these systems?
Right. So every physical assessment really stands on four pillars. You start with inspection, which is honestly just looking, observing size, shape, color, symmetry, really paying attention.
Okay, just looking. Then what?
Then comes palpation.
All right.
That's using touch, often very gentle pressure, feeling for texture, maybe tenderness, or the consistency of tissues.
Got it. And the last two?
Percussion comes next. That involves tapping, usually to figure out what's underneath, though honestly it's maybe less prominent in the HEENT assessment compared to, say, checking the lungs. And finally, auscultation. Listening, usually with a stethoscope, listening for sounds the body makes. And in this assessment, we're often focusing on blood flow sounds.
Okay, so we've got the methods. Looking, feeling, tapping, listening. Now the gear. Looking at the list of tools, it almost sounds like a miniature construction crew, just for the head and neck area. Which instruments are the real non-negotiables here?
Well, you definitely need specialized lights and scopes. You have to see into those dark corners, right? So the pen light is essential for general visual checks and those crucial people reactions. Then the otoscope for the ears and the ophthalmoscope for looking deep into the eye, the retina, the optic nerve. These are precision tools, absolutely.
And what about the simpler stuff?
Well, there's the Snellen chart. Everyone recognizes that for testing vision, visual acuity, specifically checking for impaired far vision, which is myopia. And then there's the one tool that always seems to surprise people, just a simple cup of water.
A cup of water? Really? Why?
Yeah, it's used very specifically when assessing the neck. It helps the practitioner see how the thyroid gland moves and just generally evaluate swallowing.
Okay, fascinating. Right, let's unpack this then. We should probably start systematically. Top down, from the skull, maybe, down to those critical immune checkpoints in the neck.
Sounds like a good plan. And remember, before the practitioner even touches you, they're gathering subjective data. The history is just everything. For the head specifically, we're asking about headaches, frequency, type, especially getting details about migraines with aura. That can point towards neurological or vascular issues.
Okay, and what about history related to the neck area?
They were asking about things like jaw tightness or pain, any neck stiffness, maybe hoarseness, mouth sores, or, persistent sore throats. Once that history is gathered, then we move to the objective bit, assessing the skull itself. The expected normal finding is what we call normocephalic, basically normal size and shape, and the head should be held upright, erect, and midline.
So when does it cross the line from just being maybe a slightly different head shape to a serious red flag during that inspection?
Good question. Signs for concern would be any depressions you can feel, palpable masses, or tenderness. But the really big ones are abnormal enlargements, like acromegaly. That's a critical point. Acromegaly isn't just a large head, it signals an underlying problem, usually a pituitary tumor causing excess growth hormone. So you see, that simple visual check of head size, it actually carries pretty high stakes.
Wow, okay. Now this is where I think it gets really interesting moving down to the neck. We check the range of motion flexing, extending side to side, but then there's that structural check, looking at the airway and the thyroid.
Absolutely. The neck should move freely, full range of motion, stiffness, or limited movement that's unexpected. And a really critical finding is stridor. That high-pitched, harsh sound during breathing, that's an immediate warning sign. It means severe airway obstruction.
Okay, serious stuff. Now, tell us more about that unique thyroid check with the water cup. How does that work?
Right. So the thyroid gland, when it's normal, you shouldn't really be able to see it. We first locate the isthmus, that little bridge of tissue, just below the cricoid cartilage, the Adam's apple area. Then, to assess it properly, the client tilts their head back just slightly, hyperextends the neck a bit, and then as they swallow the water, the practitioner palpates, feels the area.
White wall swallowing.
Because swallowing makes the thyroid gland move up along with the trachea, the windpipe. If the gland feels fixed, stuck in place when it should be mobile, that's a significant finding.
And what if the thyroid is enlarged?
Pugoiter, right. That's when you bring in the stethoscope. Auscultation.
Precisely. If it's enlarged, we use the bell of the stethoscope to listen over the thyroid area. We're checking for something called a brute. It's a sort of whooshing or blowing sound. It's vital because it means the gland is working overtime, basically sucking in extra blood supply to keep up.
Yeah.
It strongly suggests hyperthyroidism, an overactive state. So that sound tells you about high blood flow and metabolic distress. Got it. Okay, before we move off the neck, let's quickly touch on the lymph nodes. You mentioned immune checkpoints. This is the body's early warning system, right? And heavily concentrated here. Exactly. These nodes are critical. They filter the lymph fluid and engulf pathogens, bacteria, viruses. To check them, we use the pads of our index and middle fingers. Gentle, circular motions, and always compare side to side, bilaterally.
So if I just have a regular cold, my nodes might feel swollen, right? How do you tell the difference between that kind of normal immune response and a major red flag?
That is the critical distinction. Expected nodes. You shouldn't really feel them easily. They should be non-tender, movable under the skin, and certainly not visible. Now, if you have a cold, yes, they might swell up a bit and feel tender. That just means they're busy doing their job fighting the infection. The real red flags are nodes that feel firm, almost hard, fixed in place like they're stuck down, and crucially, non-tender. That combination rigidity and lack of pain suggests something potentially more concerning than just a standard infection. Okay, firm, fixed, and non-tender. Got it. Let's move on to the face now. You said the key finding here is symmetry. Symmetry of features, expressions, basically checking nerve function.
That's the core of it, yes. Checking the integrity of the cranial nerves that control facial muscles. So any asymmetry is an immediate issue. If one side of the mouth droops or an eye doesn't close properly, that points right away to possible paralysis. Cranial nerve problems. Other unexpected things we might note are, say, excessive facial hair on a woman, hirsutism, which often points to an endocrine or hormonal issue like PCOS, or even periorbital edema, puffiness around the eyes.
And to test for that subtle drooping or weakness, the client gets asked to do a series of facial movements, right? Sounds almost like a little performance test.
It kind of is. We need to test the major muscle groups innervated by those nerves. So we ask them to smile really big, show their teeth. We're looking specifically for the nasolabial fold, that smile line from the nose to the corner of the mouth. Is it present and equal on both sides? We have them puff out their cheeks, and the assessor gently presses on them. Does the air escape equally, or does one side collapse? And finally, asking them to raise their eyebrows way up and then close their eyes really tightly, resisting attempts to open them. We're looking for perfect mirrored movement throughout. Any weakness is a flag.
Okay. Now, shifting to the nose and sinuses, you mentioned asking about discharge, but objectively, the inspection seems to rely heavily on the color of the nasal lining, the mucosa, like a built-in color code for diagnosis.
It absolutely is. It's a fantastic visual diagnostic tool. Expected findings. The nasal mucosa should be moist and pinkish. The nose itself, symmetric and midline. But yeah, the color tells a whole story about the immune system's reaction right there.
Okay, give us the code. What do the different colors mean?
Right. So pale, maybe even boggy-looking mucosa, often with clear, watery discharge. That's your classic allergic response. The tissue is reacting to an allergen. If you see bright red nasal mucosa, think inflammation. That's typical for an upper respiratory infection like the common cold. And then if you see yellow or greenish discharge, that often points towards a bacterial infection, likely in the sinus cavities.
Fascinating. Okay, moving into the mouth and throat. What really stands out to you during that inspection? It seems like there are a lot of surfaces to check.
There are. We look at the lips, color, moisture, any cracking or lesions. We check the teeth condition, any missing ones, the tongue, its mobility, does it stick straight out midline, any sores or coating. We also check the roof of the mouth, the hard and soft palates, make sure they're intact. But yeah, the tonsil check and the uvula check are pretty crucial.
The uvula, that little punching bag thing at the back. Why is that so important?
Huh. Yes, that's the one. It must rise symmetrically right in the middle when the client says, ah. If one side of the soft palate fails to rise, pulling the uvula over to the good side, that again points straight back to a cranial nerve deficit. It often confirms what we might have suspected from the facial symmetry check. And of course, we're looking at the tonsils too. Are they enlarged? Do they have exudate, that whitish pus or discharge on them? Clear signs of infection like strep throat.
Okay, let's switch focus now to the ears. Subjectively, what are the key things you're asking about?
For the ears, we ask about tinnitus. That's the medical term for persistent ringing, buzzing, or hissing sounds. Huge impact on quality of life for some people. We also check for any hearing changes, of course, ear pain, using that PQRST method maybe to evaluate it, and dizziness, or specifically vertigo, the feeling that the room is spinning.
And objectively, when you look inside the ear, how does the technique differ? I heard it changes for kids.
It does. First, externally, the top of the ear, the auricle, should roughly align with the outer corner of the eye. That's just a baseline check. When using the otoscope to look inside, technique is really key for getting a good view, and importantly for safety. For adults, you gently pull the auricle up and back. For young children, though, you pull it down and back. It's simply because the angle of the ear canal changes as we grow. That slight change in pull straightens the canal out for viewing.
And what are you looking for once you get that view? The eardrum, right? The tympanic membrane, or TM.
Exactly. The TM, it's the barrier between the outer and the middle ear. The expected healthy finding is that it should look translucent, kind of a pearly gray color, oval-shaped, and slightly concave, pulled inwards just a bit. The red flag here is usually pretty immediate and visual. A TM that looks angry red, maybe bulging outwards, and is painful for the patient. That's classic for a middle ear infection, otitis media.
Okay. And then there are quick hearing checks, too. The whisper test and the RIN test.
Yeah, they're fairly simple functional checks. The whisper test is exactly what it sounds like. You stand about 1 to 2 feet away, cover one of the patient's ears, and whisper something simple, like a 2-syllable word or numbers. See if they can repeat it. The RIN test is a bit more specific. It uses a tuning fork to compare how well the person hears through bone conduction, placing the vibrating fork on the mastoid bone behind the ear versus air conduction holding it near the ear canal. It helps distinguish different types of hearing loss.
Interesting. Okay, let's switch over to the eyes now. Everyone's familiar with the pupil check, shining a light, but there's that mnemonic pure RLAA. Can you unpack what's really packed into that?
Sure, PRLA is just a great way to remember all the crucial checks for the pupils. PICR stands for pupils equal, round. Pretty straightforward. Are they the same size and shape? RLL means reactive to light. Do they constrict properly when you shine a light, both the direct eye and the other one? Consensual response. And the final A is for accommodation. That's testing their ability to adjust focus when they shift their gaze from looking at something far away to something up close, like your finger. The pupils should constrict slightly and the eyes should converge. If the pupils don't react equally or aren't round or don't accommodate, that often suggests a significant neurological issue, an interruption or injury somewhere along the nerve pathways.
Makes sense. And the Snellen chart for visual acuity, that 20/20 number is famous. But what does it actually mean if someone has, say, 20/40 vision? How do we interpret that in real terms?
Right, it's a ratio comparing the person's vision to a standard normal. So 20/40 vision means that the client has to stand 20 feet away from the chart to read a letter that a person with normal visual acuity could easily read from 40 feet away. Essentially, you have to be twice as close as the standard baseline to see the same level of detail. That's how we screen for impaired far vision or myopia.
Gotcha. Okay, and finally, for the eyes, eye movement, why is testing the 6 cardinal positions of gaze so important? Following the finger in an H pattern.
That test checks the integrity of 3 different cranial nerves, the 3rd, 4, and 6, which control all the tiny muscles that move the eyeball. Movement should be smooth, coordinated, and symmetrical between the 2 eyes as they follow your finger through those 6 points. Unexpected findings would include nystagmus, that's an involuntary, often jerky or cyclical movement of the eyes, or strabismus, which is an obvious misalignment where the eyes aren't pointing in the same direction. Both suggest that the motor signals to the eye muscles are disrupted somehow.
Okay, that covers a lot of ground. But you mentioned context is key. How does all this change when assessing an older adult? Normal aging must affect the baseline, right?
Absolutely. It's crucial not to mistake typical age-related changes for, a red flag or pathology. The baseline shifts.
So how does aging affect the actual structural look of the face and head?
Well, facial bones, particularly around the eye orbits, can start to appear more prominent. That's often because there's a decrease in skin elasticity and a loss of that subcutaneous fat layer underneath. Also, if teeth are lost, the whole lower face structure can look smaller, maybe sunken in a bit. And particularly in women, post-menopause, hormonal changes can sometimes lead to hirsutism, some noticeable facial hair growth.
And what about the sensory changes themselves, the actual function?
Sensory decline is unfortunately pretty common with aging. For the eyes, you often see decreased tear production leading to chronic dry eyes. The sense of smell often decreases too. And the ears definitely face challenges. You tend to see increased cerumen or earwax accumulation, sometimes thickening of the eardrum itself. Maybe the earlobes look a bit more pendulous or stretched. And of course, hearing loss is very common.
Right. And your sources highlighted something important about the social impact of those hearing changes.
Yes, and this is a really vital point for listeners to understand, I think, that perceived inability to hear clearly. It often manifests as the older adult feeling like people are mumbling around them. This can be deeply isolating. It can lead them to withdraw from social situations, from groups, because it's just too much effort or embarrassment. And that withdrawal can significantly impact their overall mental health and well-being. Understanding that social dimension, that's part of a truly comprehensive assessment, too. It's not just a physical check. It's looking at the whole person.
Wow. Okay, so we've really covered the systematic approach to the HEENT assessment today. We've gone from the subjective history, asking the right questions, all the way through to specific inspection points, those visual and tactile clues that immediately help differentiate expected health from potential illness. We've definitely seen the value of looking for symmetry, those color codes in the nose, assessing movement in the neck, face, eyes, all these rapid indicators of potential systemic issues.
The real value here, I think, lies in that precision. Knowing the subtle difference between lymph nodes that are just a bit tender because you have a cold
Blech.
and those that feel fixed and firm, that could be the difference between diagnosing a simple infection and detecting something much more serious much earlier.
So wrapping this up, what does this all mean for you, the listener?
Well, I think the big takeaway is how deeply interconnected all these systems are. This assessment really reveals that. So maybe next time you look in the mirror, consider this. Something as subtle as a slight change in the color of your nasal lining, or maybe feeling a single lymph node that feels a bit different, firm, not tender. That might not just be some isolated annoyance. It could be a critical piece of information about your body's overall immune activity or state of health. Think about it. What expected findings are you confirming for yourself every day? And are there any subtle shifts that maybe now you realize might be worth a deeper look?